Okay, today class is we are going to be talking about pulmonary disease. Okay, pulmonary disease are divided in two main groups. Okay, this one is the first one, that is obstructive pulmonary disease. Obstructive pulmonary disease is one of the main characteristics is increased resistance to airflow. So that means because you have resistance to airflow, those patients most of the time have air trapping. Okay, the lungs are increased and they retain air, okay, especially CO2. Okay, right here we have the first etiology, the first disease, that is asthma. Okay, asthma is more prevalent in childhood, but also could happen in adulthood. Okay, asthma is an airway obstruction that is reversible. Okay, this is one of the main characteristics of asthma. Asthma is a type of COPD, and the main difference is reversible. Okay, with medicine, you reverse the condition. Airway inflammation, increased airway responsiveness, because most of the time it's due to allergic reaction. Okay, all the people that have asthma, they are also allergic, have like atypic components. In asthma, we have two types: intrinsic, that is non-allergy, especially adulthood. This slide is extremely important. And extrinsic, that is allergy, and it's a pediatric onset. So that means that you develop in the early childhood. In the extrinsic, 1/3 to 1/2 of asthma cases all are extrinsic, and they are related to immunoglobulin E. Okay, and the treatment for asthma, most of the time is the same. Okay, either intrinsic or extrinsic. Okay, uh, there are inhaler. Okay, inhaler beta agonist. Okay, short acting, long acting, and also inhaling corticosteroid. The intrinsic develop in the middle age when you are like 20s. No history of allergies, respiratory infection, or psychological factors appear to be contributory, and allergen-specific immunotherapy and environmental control not helpful. Exercise-induced asthma, those are the patients that is gonna go to the office saying that when they are like doing exercise, when they start doing exercise, they have like shortness of breath. Okay, it's not the lack of exercise because they have responses in the airway to all the substances that are secreted during the exercise, and they develop what is called exercise-induced asthma. Okay, occupational asthma is because of you are working in one job that you are exposed to substance that produce allergy, and if the patient is susceptible to allergy, the patient is gonna develop asthma. Drug-induced asthma, there are some types of drugs that produce problem in the lungs, and the patient develop asthma symptoms. Okay, like aspirin, NSAID, especially aspirin, because there is also one probably there is aspirin-induced asthma. Okay? Food additive can also trigger asthma. Remember that always asthma is related with allergic reaction. Okay, then there are some food that produce allergic reaction. Pathogenesis in immunohistopathology, fissure, edema, mast cell activations. That's why you have immunoglobulin E, and this histamine. Okay? Histamine is one of the mast cells that produce asthma. Okay, cell inflammation by neutrophil and eosinophil, inflammation of the airways, acute bronchospasm, mucosal edema, mucus plug formation. That mucus plug formation is more related to other diseases, okay? We have question number 1. Which disease has increased airway responsiveness to various stimuli, okay? What is the answer? Exactly, it's D right here, okay? We are gonna be covering chronic bronchitis. Chronic bronchitis is a type of COPD, but it's more related with chronic cough, okay? And they have 9 criteria, okay? Emphysema is extremely linked to smoking, also chronic bronchitis, and cystic fibrosis is a genetic disease, okay? Allergic asthma, pathogenesis, of course, is immunoglobulin E mediated, manifest by elevation of immunoglobulin E, allergic rhinitis, eczema, all those are part of the allergies, okay? Also, contact dermatitis, also extremely related with those patients, okay? Allergic asthma, mechanism of action, exposure to specific antigens that have previously sensitized mast cell. Of course, has to be exposed to the cell, you develop the antigen that is you develop the antibody that is the immunoglobulin, and then when you are exposed against is when you have the allergic reaction. Pathogenesis, normal respiratory epithelium replaced by goblet cell result in mucus edema. Remember that the goblet cell is the one that secretes mucus, okay? It's a unicellular gland that produces mucus. That's the definition of goblet cells. And secretory mediator response occurs 6 to 12 hours later. More refractory to treatment. Clinical manifestation. This is a special clinical manifestation of asthma and also all the COPDs, okay? Wheezing, okay? Feeling of tightness of chest, of course, dyspnea, cough, could be dry or productive. Productive means that you have mucus. Hyperinflated chest, of course, decreased breath sound. Clinical manifestation of severe attack, use accessory muscle of respiration, intercostal retraction. You could see that if you take off the upper part, the clothes of the patient, the upper part, and in the ribs, between the ribs, you could see the intercostal retraction. Okay? Distant breath sound, wheezing, ornea. Ornea is the patient when they get laid down, they have shortness of breath, okay? And agitation. Clinical manifestation, tachypnea, that's breathing, tachycardia, rapid heart rate, wheezing is not a good indicator, PEFR less than 80 milliliters per minute, okay? Diagnosis, you have to do a radiography and you're gonna see that it's a hyperinflation of the lungs and flattening of the diaphragm. That's a special, okay, in the X-ray. Physical findings, sputum examination. Most of the time you don't do any sputum examination, but when you see the X-ray and also you do pulmonary function test, okay? You see, pulmonary function test is the best to diagnose the patient, and this is the ratio that you have to follow, okay? FEV1 over FVC less than 75. That means that is obstructive, okay? Normally, that ratio is around 80. So you are below 80, obstructive. You are above 80, restrictive. Okay? Also, you do AVG. Extremely important to do AVG in patient with asthma, okay? Because you have to check the CO2 in those patients. Okay? It's extremely important. Why? Because if the patient, if you see that the patient have, also you have to check the saturation rate. If the patient have saturation rate low and the CO2 start improving, then that's an alarm. Okay, you have to intubate the patient. Okay, that's the worst part of asthma. That means that the patient is exhausted, is like fatigue. They are not using more the accessory muscle, and they are uh, retaining. Sorry, if you see that the CO2 start increasing, you are gonna see that the patient is retaining more CO2, and you have to intubate the patient. Okay, because normally patient with asthma, the CO2 is low, a little bit low, because remember that they are breathing really fast, and when you breathe really fast, you get rid of the CO2. Okay, treatment is always avoid trigger, environmental control, preventive therapy, and desensitization if you have any allergies. Okay? But the treatment for asthma is the same. Okay, basically for any type of asthma, except when you have asthma-induced, exercise-induced asthma, that you use the inhaler beta agonist like 30 minutes before you start doing exercise, and the patient improve a lot. Well, normally you start the patient with inhaler, what is called SAVA, okay? Like this, SAVA, and is inhaler with SAVA. Okay, the most famous is albuterol. Short SAVA means short-acting beta agonist. So the patient with asthma, according to the severity of asthma, because asthma have like classification, you put the patient in SAVA as needed. Then if the patient don't improve, you add inhaled corticosteroid. If the patient don't improve, then you add LAVA, that is long-acting beta agonist. If the patient don't improve, you increase the dose. If the patient don't improve, you add systemic steroids, and then there is no more therapy. Okay, so most of the time you have to be very careful with patient with asthma, and you have to check if the patient is getting the therapy as it should be. Okay, because most of the time they don't know how to use the inhalers. Okay. Acute bronchitis is etiology. Acute inflammation of the trachea and bronchus. Cause is a vital or non-vital heat, smoking, inhalation. Asthmatic bronchitis is swelling of the bronchial mucosa in children associated with obstruction, respiratory distress, and wheezing. Acute bronchitis pathogenesis, airway become inflamed and narrow from capillary dilation, swelling from fluid, inflammation with infiltrated with inflammatory cell, increased mucus production, loss of ciliary function. Those are characteristic. Okay. Clinical manifestation usually mild to self-limited. Okay. Cough could be productive or non-productive, low-grade fever, sore throat, fatigue. Diagnosis, clinical presentation, distinct hallmark of disease, recent onset of cough, chest X-ray to distinguish acute bronchitis from pneumonia. Okay, nobody know what is the difference of acute bronchitis from pneumonia in the chest X-ray, because that's how you differentiate acute bronchitis from pneumonia. Okay, the difference is easy because the presentation most of the time is similar. The patient is gonna have cough, shortness of breath, fever. And then when you do the X-ray, it's normal. Acute bronchitis, normal checks X-ray. Pneumonia, you see infiltration in the X-ray. Okay, that's the main difference. Treatment, usually there is no treatment because most of the time it's viral. Okay, most of the time when we have viral infection, we don't give any treatment to the patient. Okay. If the patient don't improve with normal measurement, control the fever, give plenty of fluid, the patient don't improve by 3-4 days, then you have to start thinking in antibiotic, okay? Because maybe it's a bacterial infection, okay? Avoid smoking, use of vaporizer in bedroom. Chronic bronchitis causes cigarette smoking is the most common one, repeat airway infection, genetic dispositions, okay? And this is extremely important in chronic bronchitis because it's a time criteria, okay? You have to make that criteria in order to diagnose chronic bronchitis, okay? If you don't meet that criteria, it's impossible that you diagnose chronic bronchitis, okay? Etiology is type B COPD. You're going to see that we have type A, that is emphysema. It's a blue bladder because the patient is going to breathe like with the lips really close. Let me see. You see, this is the criteria. The patient need more than 3 months of cough in 2 consecutive years. Okay? Persistent, reversible, that's the ratio, that's the age, that's not really important. Pathogenesis, chronic inflammation and swelling of the bronchial mucosa resulting in scarring. That's extremely important because that's the pathology. Okay? Also, they have elevated interleukin A, elevated CD4, hypertrophy of the bronchial mucosa and gland goblet cell. That's extremely important because it's another description of the pathophysiology. Okay. Pathogenesis, increased bronchial wall thickness, persistent increased wall of breathing and CO2 demands, ventilation perfusion mismatch. That's something that we measure in the lungs. Okay. Pulmonary hypertension, that could lead to pulmonary hypertension and right side heart failure. Okay. Pathogenesis, destruction of the bronchial wall, result in dilation of the airway sac. Okay, bronchiectasis. We have another disease that is called bronchiectasis. Okay, don't get confused, but you can see bronchiectasis right here. Dilated sac contain pool of infected secretions. Okay, those patients, most of the time, when you have a patient with chronic bronchitis and emphysema, most of the time, when they have an exacerbation, okay, that they get to the emergency room, you give the medications that is for the COPD. Most of the time is ipratropium, SABA, LABA, corticosteroid, all those medications, plus antibiotic, because infection is the most common trigger of exacerbation of those conditions, okay? Typically, patient is overweight, commonly associated with emphysema. Emphysema is another type of bronchitis. Shortness of breath, excessive sputum, chronic cough. That's the main characteristic. Okay. Cyanosis. The patient could develop cyanosis due to because they close the mouth. Diagnosis is through the chest X-ray and especially pulmonary function test. In this one, is gonna have the same. The ratio is gonna be lower than 80. Okay? And another characteristics, the total lung capacity is gonna be increased. Okay, residual increase and residual volume also is gonna be increased. Okay. For bronchitis, of course, you have to do the ABG. You're gonna see elevated PaCO2, decreased PO2. You could do an EKG. It's not normally routinely do, but you could do an EKG to see if there is any atrial arrhythmia. Okay, and also you do a CVC because as a compensatory mechanism, most of the time due to the cyanosis, the patient develop polycythemia. That is, hemoglobin is going to be really high. Okay, the treatment is the same for any COPD. You have to use the ipratropium, the short-acting beta agonist, long-acting beta agonist, and steroid. Okay? Medication, you're gonna see short-acting beta agonists, anticholinergic, that's ipratropium, antimicrobial. Remember that most of the time you put those patients in antibiotic. So those O2 therapy, you have to be very careful with patients with COPD when you give O2. Okay, I'm gonna explain that in the next pathology, that is emphysema. Okay? Management, of course, you have to stop smoking, bronchodilator therapy. Okay, adequate rest, proper hydration, physical reconditionings. Okay, you have to do exercise, and this is extremely important in COPDs. Okay, COPDers. Okay, you have to get those vaccine. Okay, influenza and pneumococcal vaccine, because those patients are immunocompromised due to the use of steroid most of the time. Okay. Now, right here we have the emphysema. Uh, Emphysema is the destructive chain of the alveolar wall with fibrosis. Okay, fibrosis. Why? Because remember that emphysema is most of the time triggered due to smoking. Okay, it's the smoke when get to the lungs, they activate the macrophages. Macrophages activate other cells, and they destroy uh, the alveolar wall. Okay, smoking, air pollutions, and this is a special type of emphysema. Okay, that's a genetic, and it's an alpha-1 antitrypsin deficiency. Antitrypsin is the one that inhibit elastase, and elastase is the enzyme that destroy the alveolar wall. Okay, as the patient with that deficiency develop emphysema. And it's easy to identify because it's a patient that is gonna present with all the signs and symptoms of emphysema, but no history of smoking or little history of smoking. Okay, so don't get confused. You have patients in the 40 that they smoke like from 30 to 35, like for 5 years, they could have alpha-1 antitrypsin. Because in order to develop emphysema from smoking, you need long history of smoking. Pathogenesis, group of genes, release of proteolytic enzymes. You see, and those proteolytic enzymes are the ones that damage the alveolar wall. Okay. Pathogenesis, reduction in pulmonary capillary bed, excess of O2 and CO2 between alveolar, that's retaining of air in the lung, okay? Loss of elasticity of the tissue, so the lungs lost the ability to expand and record. Air become trapped in the distal alveoli, loss of alveolar wall, air trapping lead to bullae. Okay. Classification, we have centroacinar, and we have anacinar. Okay, that's, and also parasectal. Those are the classification of emphysema. Clinical manifestation is the same, is shortness of breath, all those the manifestation of air difficulty. Okay, and those patients most of the time are cachexia. Okay, you can see are extremely thin, and they use accessory muscle, pulses lip bleeding, they have cough, digital clubbing. You could see digital clubbing is, you could Google it in the internet. It's basically a deformation in the at the tip of the nail, and it's due to the hypoxia. Okay, you could see this in those patients, but most of the time digital clubbing is more related with cancer. Okay. Barrel chest is also common in those patients. Barrel chest means increase the anterior-posterior diameter of the chest. That's what means barrel chest. Okay. Emphysema diagnosis, of course, you have to do pulmonary function tests. You do chest X-ray. You're gonna see this hyperinflation and flattening of the diaphragm. You could do an EKG, AVG, extremely important. Remember that you have to check the oxygen saturation rate, the PCO2, PO2. Okay. Diagnosis is due to the patient history. Okay, common finding you can see right here. The patient is gonna be like medicine when the patient is thin and his waist is called cachexia. Okay, using accessory muscle, decreased breath sound, prolonged expirations, decreased heart sounds, hyperresonance. Okay, treatment O2 therapy. You have to be very careful. I was saying that I'm gonna explain right here. You have to be very careful with O2 therapy. Okay, patient with emphysema, due to that they have problem in the lungs, okay, chronic problem in the lungs, they lost the ability to the normal response to breathing, okay, because we breathe not because we need oxygen, we breathe because we have excesses of CO2 in the lungs, okay, and due to that those patients retain a lot of CO2 and a lot of air in the lungs, they lost that ability. So they are gonna breathe because they really need air. Okay, so that's why it's extremely important. You could give O2 therapy to those patients, but the oxygen saturation rate has to be less than 92. Sorry, less than 92. Okay, so you have to be very careful. You go beyond over 92, then the patient is gonna worse. It's gonna get worse. Okay, uh, let's keep going. Bronchiectasis, the dilation of the bronchial wall is acquired, is rare, most common is congenital, associated with cystic fibrosis, extremely associated with cystic fibrosis because they develop the mucus plug. Okay. Pathogenesis, recurring infection of bronchial wall lead to persistent dilation, bronchial wall thickening, inflammation result in destruction of the wall. Okay, destructive process lead to loss of ciliary epithelium, transform to squamous cell, and post-formation lead to bronchial obstruction. Clinical manifestation, persistence, daily, chronic, productive cough, purulent, false smelling, that's extremely common in those patients. Okay? Hemoptysis is when you cough blood, fever, night sweat. Okay, halitosis is bad breath. Okay, skin pallor, digital clubbing. Clubbing caused by prolonged decreased oxygenation. When you have the oxygen saturation rate low, that this cyanosis, the patient develop clubbing. Okay. Diagnosis, history of chronic productive cough, checks, X-ray is extremely important. Okay. Pulmonary function tests, AVG, and CT. Most of the time, you have to do a CT to see the bronchiectasis. Okay, that's basically the only one air problem that you have to do CT to diagnose those patients. Treatment most of the time is antibiotic therapy because the main predisposing factor is infection, okay, recurring infection, okay. Bronchiolitis is a widespread inflammation of the bronchioles as a result of infectious agents, okay. The most common one is viral. This is a virus, okay. RSV is a virus. And it's extremely common in children less than 2 years in the winter, okay, especially winter to spring, okay, especially less than 2 years, okay. That pathology is just in childhood, okay. In adulthood, is extremely rare that you see that condition in adulthood, okay. Actually, in adulthood, you don't learn that condition in adulthood. You learn that condition in pediatric, okay, because it's just for pediatric population, basically. Okay, we have pathogenesis, proliferation, and necrosis of bronchial epithelium, production of thick, tenuous mucus, airway obstruction, atelectasis. Atelectasis is it's a problem in the lungs that they collapse. Okay, hyperinflations. Pathogenesis, possible mechanism of airway obstruction, develop inflammatory exudate, display surfactants, release of chemical mediator, inflammations, and increased bronchial muscle mass. Clinical manifestation, the patient is gonna have like wheezing, especially wheezing. Okay, the patient also could have crackles, retraction, dyspnea, difficulty breathing. Diagnosis elevated WBC because it's an infection. The most common is vital. Okay, most of the time it's vital. Checks X-ray. You do checks X-ray. Pulmonary function test is normally it's not a routine in that condition. You don't do a pulmonary function test. Also, to do a pulmonary function test in childhood is extremely, basically impossible. Okay. Okay, and then you have to do nasal swab, of course, and right there is where you see the RSV. Bronchiolitis treatment, adequate humidify oxygenation, bronchiolar agents, bronchodilator agents. Most of the time you don't do this. Corticosteroids, sedation, hydrations, antiviral, antibacterial. Now we have cystic fibrosis. Remember that cystic fibrosis is a genetic condition. Okay? It's an autosomal recessive disorder of the exocrine gland. Okay? And it's a problem in the chloride channel. Okay? The main problem in cystic fibrosis is in the chloride channels. It's a channelopathy. Okay, pathogenesis is the function of CFTR gene. That's the problem in the genetic problem in those patients, primarily affect the pancreas. Due to that, those patients have problem in the chloride channels. They develop a lot of mucus, okay, a lot of secretion, but they develop secretion in the whole body, okay, especially in the main glands of the body, like the pancreas, okay. That's why those patients have pancreatic insufficiency most of the time. Also could develop infertility, especially in male, okay, because they have a lack of the vas deferens. That's why they have infertility. High concentration of sodium chloride, especially chloride, okay, in the skin. That's how you diagnose. You have to do 2 tests. Elevated chloride, bingo, diagnosis. Now we have pathogenesis, mucus producing glands in the GI tract, enlarge, generate sexist secretions, eosinophilic mucus, secretion plaque, the glands and the duct lead to decreased production of pancreatic enzymes. That's why those patients develop pancreatic insufficiency, okay? They develop vitamin deficiency, okay, because they don't produce pancreatic juice, and the pancreatic juice is the one that we need to absorb the fat soluble vitamin, okay, vitamin A, D, K, and E, okay, D, K, and E, okay, they develop deficiency of those vitamins. Okay? So you develop vitamin A deficiency, problem in the vision, D deficiency, problem in the bone, K problem in the blood, E is problem with oxidation. Bronchopulmonary system is also affected by the thick, the mucus plug. Okay, that's why they use a medication to dissolve the mucus plug. Okay? It's one of the medications that those patients use. Clinical manifestation, history of cough, tenacious sputum, recurrent pulmonary infection, dyspnea. Those patients have a lot of sign and symptom. One of the main symptoms is failure to drive. Okay, that's one of the main symptoms in those patients. They have failure to drive due to a lack of all those enzymes. Okay? Clinical manifestations: pancreatic insufficiencies, cirrhosis of the liver, diabetes mellitus, gallstone, nasal polyps. That's especially in those patients. Okay, nasal polyps. They develop nasal polyps. Nutrition assessment: depleted fat store, steatorrhea. Steatorrhea means a lot of fat in the stool. Okay, anorexia, decreased growth rate in children that fail to drive. Okay? Diagnosis: AVG, EFT, chest X-ray, but the main diagnostic test is a chloride test. Okay. Sputums, sweat test. Okay, that's the main test. Sweat test to see the level of chloride. Okay. Treatment: aggressive treatment of respiratory infection, postural drainage, forced expiratory technique, medication, bronchodilator, recombinant human deoxyribonuclease, high doses antibiotic, influenza vaccine is a special antibiotic. Most of the time, those patients are in prophylactic antibiotic, okay, because they are susceptible to a lot of infection. Treatment: nutritional therapy. Of course, they need nutrition with a lot of calorie, okay, high protein and high caloric, okay. Of course, you have to give vitamin A, D, A, K, D, and E, okay. Acute tracheobronchial obstruction require immediate treatment, cause aspiration of foreign body, most often in the right lung due to the disposition of the lungs, anatomy of the lungs, okay, and obstruction may be complete or partial. Clinical manifestation: complete obstruction. The main clinical manifestation, the description to distinguish those patients is gonna be at 3-4 years old that was playing by himself in the room. You know, the family get like distracted, and 1 hour later, the patient develop out of the sudden shortness of breath, difficulty breathing. That is out of the sudden, boom, difficulty breathing. Then you start thinking about aspiration of foreign body. Okay. Partial obstruction, stridor, external. That's why you have to do a chest X-ray. Okay, you have to do a chest X-ray to see at what level is the obstruction. And then, according to the level of the obstruction, is the therapy that you are gonna use. Okay, you could use a bronchoscopy. You put like a camera inside the mouth right there, poop, and then you get the foreign body. Diagnosis based on the clinic, AVG, chest X-ray. Okay, and the treatment is according to the at what level is the obstruction. Okay, and you have to be very careful because the patient have a lot of difficulty breathing. You have to do emergency tracheostomy. Epiglottitis. Epiglottitis is inflammation of the glottis, of the epiglottis. Okay, right here. Most of the time is due to this bacteria. Okay. H influenza nowadays is not the most common one because we have a vaccine. So if you have a patient that have epiglottitis and is due to H influenza, then you have to look for not vaccinated patient, okay, patients that are not up to date with the vaccine. Okay? But nowadays, because we have the vaccine for that pathogens, is not common. Okay? Pathogenesis: infected agent localized in epiglottis and pharyngeal structure, cause rapid and potential fatal inflammation, swelling, airway obstruction. And one of the main characteristics of those patients is drooling. Okay, the patient is gonna be like drooling. Okay, like this. That's the main manifestation, drooling. Okay? Dysphonia, refusal of food, odynophagia. Could be odynophagia, but the most common one is this one, drooling. Okay, rapid onset of fever, uh, inspiratory stridor, and retractions. Okay, that's the in the X-ray. You see this in the X-ray. Epiglottitis. Sorry, I get confused. Okay, a child sitting a sniffing dog. That's how the patient is gonna sit because the glottis is closed. The patient also they call tripody position. Okay, and this is the finding in the X-ray. Okay, thumbprint sign. Okay. Treatment most of the time is intubation. Okay, you have to intubate the patient because you have to uh, save the airways. Okay, and then you give antibiotic to the patient. Okay? Krupp syndrome etiology is a number of acute viral inflammation disease of the larynx, trachea, and bronchi. That's the real name of the Krupp. It's a really long bacterial tracheitis is type of Krupp. Okay, occurring 4, and those are the age. Okay, from 6 to 3 years. They overlap with um, bronchiolitis. Okay, but bronchiolitis is basically the patient is gonna be like with fever, shortness of breath, and the patient is gonna have sounds in the lung. Okay, like stridors. Okay, those patients with croup they are gonna have the famous barking cough. Okay, Krupp syndrome, pathogenesis, infections. Most of the time, the infection is due to viral. Okay, I don't remember the name of the viral right now. It has to be around here. It's not right here, but let's see. You see, that's one of the main clinical manifestations: barking, cough. Okay, and not drooling. That's how you differentiate from epiglottitis. Okay. Diagnosis, clinical sign and symptom, lateral neck film. Of course, you do the lateral neck film, and you're gonna see also one special characteristic. Okay, laryngoscope to confirm presence or rule out epiglottitis. Most of the time, you don't have to do this. Treatment means therapy, oral hydrations, and if the patient is severe, then you have to give this epinephrine. Okay, epinephrine to release the inflammation. Okay. And we have question number 2. The nurse is trying to decide if the patient has croup or epiglottitis. Which sign can help the nurse determine the patient has epiglottitis? Exactly. Remember, epiglottitis, drooling. The patient is gonna be drooling. Okay. Okay, we finish right here this chapter. Any question from this chapter? Any question? Listen, in this chapter, what is extremely important is asthma, okay? You have to know about asthma, okay? Then let's go to the next chapter that is extremely long, but we are gonna cover the most important one, okay? Remember, lungs are divided in obstructive and restrictive, okay? When you do the pulmonary function test, that you see the ratio FB1, FBC, then that ratio is below 80, obstructive, above 80, restrictive. Also, the lung capacity gives you an idea. Why? Because remember, in obstructive lung disease, you retain air, okay? Because in obstructed lung disease, the problem is that you can put the air out of your body. That's why you retain the air. So those patients, the lungs are going to be extremely inflated and the total lung capacity is going to be increased. Okay. In restrictive is the other way around. The total lung capacity is going to be decreased. Okay. Because those patients can breathe because they can put air inside the lungs. Okay. Okay, result from decreased lung expansions, alterations in lung parenchyma, pleural chest wall, neuromuscular function, classification, pulmonary and extrapulmonary, characteristic, decrease in total vital capacity, in total lung capacity, everything is reduced, set the ratio, okay? ABG decreased uh, PaO2, normal decreased PaCO2, and increased pH, that is alkalosis. Fibrotic interstitial lung disease, group of disorder, a lot of disorder right here, characterized by acute, subacute, and chronic inflammation of the alveolar wall and cell. Okay, if left untreated, may progress to irreversible fibrosis. Diffuse interstitial lung disease, also called diffuse interstitial pulmonary fibrosis and other names. Remember that most of the time in medicine, one pathology have different names. Okay, diffuse interstitial lung disease pathology begin with injury to alveolar epithelial or capillary endothelial cell. Okay, persistent alveolitis lead to obliteration of alveolar capillary, the organization of the lung parenchyma, irreversible fibrosis, lead to large A-filled sac cyst. Okay, that's one of the characteristics. And we have three main pathology patterns. We have inflammation, fibrosis, and destruction. Clinical manifestation, progressive dyspnea with irritating, non-productive cough, rapid swelling, breathing, clubbing of the nail, that's clubbing finger, bibasilar and expiratory crackles, that's extra sound in the lung. Clinical manifestations, cyanosis, anorexia, and inability to increase cardiac output with exercise. Diagnosis, of course, you have to do a chest x-ray, pulmonary function test, and remember the main characteristic. You could do open lung biopsy, but most of the time this is to rule out malignancy. Okay. Tracheal biopsy, gallium 67 scan, that's like image that you use this to see better resolution. Okay. And trimming, most of the time is smoking cessations, avoid environmental exposure, anti-inflammatory agents, immunosuppressants, and if the patient don't improve, then you have to do lung transplant. Okay, sarcoidosis is an acute or chronic systemic disease of unknown causes, immunologic basis, that's the most common etiology, immunologic. Okay, activation of the alveolar macrophages to unknown trigger, first degree relative increase with 5-fold. It means that you have 5 more time risk to develop the disease. Okay, development of multiple uniform non-cascading epithelial granuloma, that's one of the main characteristics, non-cascading epithelium, non-cascading granuloma affect multiple organs and normal T cell function. This disease have an special, those are common characteristic of lung disease, but how you differentiate this, okay, that's another special characteristic, erythema nodosum. You could Google it, okay, you're gonna see that those are some part in your body that are really painful, that is erythema nodosum. Okay, that's another characteristic, hyperpigmentation. Okay, But they have one special characteristic diagnosis. In this is a special also increased calciums. Okay, also they increase angiotensin converting enzyme. That's another characteristic. Diagnosis test. Okay, they have Galodium P, bronchial. Oh my God, they didn't put the main. Okay, the main thing that you do to diagnose sarcoidosis is an X-ray, and in the X-ray you are going to see bilateral hillier lymphadenopathy. Okay, those are the lungs, and right here we have the helium. Okay, helium is present in any organ. Okay, it's the site that everything get in and out from the organ. Okay? So those patients, when you do the X-ray right here around here bilaterally, okay, they have lymphadenopathy. That's the main characteristic of that disease. Okay. Treatment management of symptoms, corticosteroid, immunosuppressant agents, hydroxychloroquine, those are medication. The main medication is steroids, okay? Now we have hypersensitivity pneumonitis, etiology known as intrinsic allergy alveolar. That is a basic allergy reaction, okay? Pathogenesis, genetic predisposition, of course, you have to be predisposed to allergic reaction. Antigen combined with serum antibody in alveolar wall lead to type 3 hypersensitivity reactions. You know what is the characteristic of hypersensitivity reaction? That is right here. Antigen antibody complex. Clinical manifestations, symptoms start 4 to 6 hours after exposure and resolve 18 to 24 hours, okay? Chills, sweating, cheering, myalgia, nausea, malaise, lethargy, headache. Clinical manifestation, intermediate, acute febrile episode, progressive pulmonary fibrosis with cough, dyspnea, fatigue, and chronic is progressive. Diagnosis agent suggested by patient history. Okay, most of the time this is a clinical. When you hear clinical diagnosis, it's because it's based on the patient history. Okay, you could do a skin test, but it's not routinely do. Pulmonary function test and chest X-ray. You always have to do that. Okay. And also you do laboratory to see how is the oxygenation, okay? Like AVG, you do WBC, AVG. And the treatment is identify the offending agents and then you prevent being exposed to the offending agent and oral corticosteroids. Occupational lung disease, etiology result from inhalation of toxic gases or foreign particles, atmospheric pollutants and pollutions. Okay. Pneumoconicosis, we have a different type of pneumoconicosis, okay? Most of the time is related to exposure, okay, like occupations, okay? In the pneumoconicosis, we have anthracosis, silicosis, and asbestosis, okay? Anthracosis is the coal minor lungs, is black lung, silicosis is exposed to the silica, and asbestosis exposed to the asbestos, okay? And this is special because that can produce bronchogenic carcinoma, okay? Or another, I don't remember the other one that is really well known in the TV. They are always talking about that. Now we have pathogenesis of occupational lung disease, pollunt interface, and paralyzed cilia interfere with ciliary actions, impaired clearance effect. Remember that one of the main functions of the cilia is to clean the lung from foreign particles. Okay. Pathogenesis, alveolar macrophages try to engulf and remove particles. Macrophages release lysosomes to control foreign particle activity. Enzymes damage the alveolar wall. Okay, it's basically the same like smoking. Okay, clinical manifestation symptoms depends on predisposition factor. Pneumoconicosis produce no sign or symptom in early stage, usually symptom-free 10 to 20 years. Okay, that's why you have to, when you see a patient with those characteristics, you have to do a good interview with the patient. Okay, and you have to ask for past history. Okay, your history of working. Okay. Income manifestation, progressive productive cough, dyspnea with resections, a clinical feature, chronic hypoxemia, core pulmonal, and respiratory failure. Diagnostic, always you have to do a chest X-ray, pulmonary function test, and AVG. The treatment is preventive measurement. Okay, preventive measurement and prevent further exposure. Okay, that's one of the main treatment. Also, corticosteroid. Most of the time in those inflammation process, you have to do corticosteroid. Remember that corticosteroid, that is a type of steroid, are special for inflammatory process. Okay. Also, you could do inhaled bronchodilator, oxygen therapy. And we have question number 1. Pneumoconicosis, disease of the lung. And then we have A, deform the chest wall and pleura. B, are effective treated with antibiotics. C, produce antibiotics to the associative agents and damage alveolar wall from macrophages impairment. What's the answer? Remember, pneumoconicosis is exactly it's D because it's like the same mechanism of the smoking. Okay, you activate the macrophages and that damage the lungs. Okay. Now we have ARDS. ARDS is acute respiratory distress syndrome. Okay, acute respiratory distress syndrome is a damage to the alveolar capillary membrane, cause widespread protein-rich alveolar infiltrate and severe dyspnea. Occur in association with other pathophysiology processes, especially in patients that are hospitalized. Okay, that's basically always you are not going to receive a patient with ARDS. Okay, you develop ARDS in the hospital. And then we have etiology, more than 150,000 cases per year, mortality rate 30 to 63 because it's a really serious condition. Cause severe trauma, sepsis, aspiration of gastric contents, fat embolism, and shock. You see, all the cause is patients that are already in hospital. Okay? So those patients that are in ICU and then they develop respiratory failure, then you start thinking about ARDS. Increased permeability of the pulmonary vasculature, flooding of the alveolar wall, is proteinaceous fluid. Okay, I'm gonna explain, let me see. Okay, ARDS, you are gonna have this, the blood vessel, and this is the alveolar sac. What happened in ARDS? That for some reasons, okay, remember those patients are either have a shock, trauma, sepsis, any condition, then you start secreting substance, okay, and those substance accumulate right here, okay. So this space from here to here is the diffusion capacity of the oxygen. Okay? If you increase this gap, that means that this is the blood vessel, and the alveolar is gonna be like this, So now you have all this gap. The oxygen doesn't have the ability to go from here all the way down right here. Okay? So then you develop the ARDS. Clinical manifestation, history of precipitant event that have led to a low blood volume stage. It's a shock. Early sudden marked respiratory distress, a slight increase in pulse rate, dyspnea, and so on. Late manifestation, tachycardia, tachypnea, hypotension, marked restlessness, frosty secretion, crackles. Okay. Diagnosis, you have to do always an AVG, okay, and checks X-ray, but especially AVG to check for hypoxia, acidosis, and hypercapnia. Hypercapnia. Somebody know what means hypercapnia? Nobody know what means hypercapnia? Hypercapnia means elevated CO2. Okay, that means hypercapnia. Diagnosis, pulmonary function tests, and sometimes you have to do open lung biopsy. Most of the time you don't do open lung biopsy, okay? Because that's a clinical condition, then you treat with the medication, okay? Most of the time you treat the underlying condition. Once you improve the underlying condition, the patient is gonna get better, okay? You see, mostly supportive. That's why you have to treat the underlying condition. When the underlying, the patient is in shock. When the patient get out of the shock, the patient is going to improve the ARDS. Treatment, volume ventilator use pressure support. That's another main treatment for those patients, okay? Because those patients are gonna be in ventilator. Then you have to work with the ventilator. You don't have to know this part because it's extremely complicated, okay? But you have to know that those patients are gonna be in ventilator, okay? Treatment, supplement O2, FiO2, those are parameters of the ventilator, okay, that you manage. High frequency jet ventilations, increased ratio ventilations, inhaling nitric oxide. Nitric oxide produces vasodilation. Now we have IRDS, okay, this is in infant respiratory distress syndrome, okay. So ARDS is for adult, okay. This one is for childhood, okay. Incidence 50% for infants born less than 30 weeks. That means premature, okay. Those preemie, the preemie are the ones that is gonna develop that disease, especially preemies, okay. In term infant, you don't see that condition because that condition is due to lack of surfactant, okay. Characteristic is hemorrhagic pulmonary edema, just atelectasis, that's due to lack of surfactant. And sometimes that disease is called like this hyaline membrane, okay. Hallmark is hypoxemia that is refractory to increased level of oxygen supplementation. And right here we have a problem, okay, because oxygen in newborn baby produce ice problem, okay. If you have to give oxygen, you give oxygen to the newborn baby, okay. High risk factor, birth prior to 25-week gestation, birth and advanced gestational age, poor controlled diabetes, delivery after antepartum hemorrhage, C-sections without antecedent labor. That's because you do C-sections, the patient is not gonna have any stress. If the patient doesn't have any stress, you don't produce esteroid, and esteroid is the one that measures the lungs. Okay, perinatal asphyxia, previous infant with RDS, Rh factor incompatibility. Pathogenesis, primary cause is lack of surfactants. That is the one that facilitates the work of the lungs. The neonate with IRDS must generate high intrathoracic pressure. Pathogenesis, increased work of breathing and decreased ventilation. Lack of inflammatory exudates is the one that produces the hyaline membrane. Okay. Pathogenesis, secondary cause is immature of capillary blood vessel, lead to BQ mismatch. That's something that you measure in the lungs to see the oxygenation, the perfusion of the lung. Early clinical manifestation, we have swallow, respiration, diminished breath sounds, intercostal, subcostal, other retractions, flaring of the nerves, that's in the nose, hypotension, bradycardia, peripheral edema, low body temperature, oliguria is that the patient doesn't pee, tachypnea. Lay, then we have the central cyanosis, because cyanosis could be peripheral and central. Okay. Diagnosis, of course, you have to do the AVG and then you have to do the chest X-ray. Okay. Diagnosis, lecithin, ethingomyelin ratio. Nowadays, that is not used. Okay, you don't do this nowadays. Okay, but they use back then. They used to use it to see the maturation of the lung. Okay. Treatments, prevention is primary goal. Prenatal antenatal corticosteroid. Of course, you are gonna do a cessation. You have to, if the patient is premature, you have to give corticosteroid, okay, to facilitate the maturation of the lung. Okay. Treatment, exogenous surfactant administrations, high frequent ventilations, and also you have to give antibiotic because those patients are susceptible to infection. Okay? Fluid and electrolyte balance, minimal handling, and neutral thermal environmental. And we have question number 2. A nurse is teaching the staff about adult respiratory distress syndrome and infant respiratory distress syndromes. Which information should the nurse include in both ARDS and IRDS? Okay, what you have to include is the pulmonary compliance. Remember, pulmonary compliance is the main pathophysiology, okay? So there is no gas interchange, and then that's why the patient developed the respiratory failure, okay? Pneumothorax, etiology, accumulation of air in the pleural space, okay? We have primary pneumothorax. In primary pneumothorax, we have a spontaneous pneumothorax occur in tall, thin men or woman, could be either in the 20 or in the 30. Okay, but that's the main characteristic. Tall and thin people are at risk to develop spontaneous pneumothorax. Okay, cigarette smoking and secondary pneumothorax result of complications from pre-existing pulmonary disease. Okay. Etiology, catamenial pneumothorax associated with menstruations, primary in right hemothorax, and associated with endometriosis. That's extremely rare that you see that. Okay, that's not really common. Tension pneumothorax, yes, tension pneumothorax most of the time is due to a trauma. Okay, And one of the main differences is that the tension pneumothorax, you are going to have the lungs right here, okay? And in the middle, you have the trachea. You have the trachea like this, okay? Mean that the trachea is deviated to one side, that means that you have the tension pneumothorax in this side. Okay, so deviation of the trachea give you an idea that you have a tension pneumothorax. Okay, spontaneous pneumothorax, most of the time what happens is deviation to the trachea to the side of the pneumothorax. Pneumothorax pathogenesis primarily rupture of the small subpleural blades. Okay, that's the main characteristic. That's the description of the pneumothorax. Okay, secondary result of complication from underlying lung problem. Okay, tension pneumothorax result from building up an air under pressure in pleural space. Air entry pleural space during inspiration but cannot escape during expirations. Pathogenesis open suction chest wall wound. The air entering during inspiration but cannot escape during expiration lead to shift of mediastinum. Okay. Clinical manifestation, the patient is going to have a small pneumothoraxes are usually not detectable. If the pneumothorax is less than 20%, okay, that you are gonna see that on the X-rays. It's really small pneumothorax. You don't do anything. Okay, the patient is gonna recover by itself. Okay, tachycardia, decrease of or accent breath sounds, hyperresonance. That's one of the main characteristics. That's a sound in the lung. Sudden chest pains on affected side, dyspnea. Tension and large spontaneous pneumothorax are an emergency situation. Okay, and in those patients, you have to do chest tube. Pneumothorax diagnosis, AVG, EKG, chest X-rays is the best test. It's the primary test that you're gonna do, chest X-ray. Treatments management depend on the severity. Okay? The lung collapse, 15 less than 15 to 25%. Patient may not be hospitalized. Okay, the patient is gonna recover by itself. If the pneumothorax is really large, then you have to do the chest tube to release the oxygen. Okay, I mean the air. Treatment chemical pleurodesis promote adhesion of visceral pleura to parietal pleura to prevent further rupture. Okay. Thoracotomy is basically the an invasive procedure. Okay. Now we have remember, pneumothorax is accumulation of air in the lungs. Pleural effusion is accumulation of fluid in the lung. Okay. Pathology, collection of fluid or pus in the fluid could be, pus is a type of fluid, could be like triglyceride, like lipids, could be blood, any fluid that is accumulating in the lung. Okay. 5 major types. We have transudates and exudates. Okay. Let me see. Empyema, hemothorax, chylothorax. Oh, okay, listen. This is the main pleural effusion are divided just in transudate or exudates. Okay, those are the pleural effusion. Okay. Now, in those category, okay, hold on. Hello, hello. Can you hear me? I have some technical problem, but I'm here. I'm back. Okay, let's keep going. Okay, I was saying that uh, Eurofusio is divided not in five. Okay, it's divided into transudate and exudate. Transudate is more the protein is low. Okay, exudate is rich in protein. Okay, transudate could be due to severe heart failure. Okay. Exudate could be to malignant infection like tuberculosis, pulmonary embolism, sarcoidosis, okay? Then that fluid, that collection of fluid could be due to like empyema, that accumulation of pus in the pleural space, okay? And it's high protein exudate. You see, it's a type of exudate. So don't get confused. It's not divided in five types, okay? It's just two types, okay? This is a type of exudate. Okay? Hemothorax is accumulation of blood, okay? It's accumulation of blood in the pleural space. Chylothorax and lymphatic is also a type of exudate, okay? So don't get confused, it's just two types, okay? Pleural effusions causes change in pleural capillary hydrostatic and colloid-oncotic pressure or intrapleural pressure. Okay? Imbalance in pressure associated with fluid formation and excessive fluid removal. Pathogenesis, we have transudates. Remember, transudate most of the time is decreased to hydrostatic or decreased to oncotic pressure when you have renal or hepatic problem. Exudate is increased production of fluid, increased permeability of pleural membrane, impaired lymphatic drainage. Clinical manifestation vary depending on cause and site of effusion, may be asymptomatic, less than 90 milliliters, dyspnea, decreased chest wall movement, pleurity pain, dry cough. That's one of the main characteristics. Okay. Also, when you remove the fluid, also could produce dry cough. Clinical manifestation, accents of sound, dullness to percussion. You remember in hemothorax, we have hyperresonance. Now we have dullness to percussion. Okay? Decreased taltive fremitus, that happens in both. Okay, that's a sound. That's why I don't know if you heard sometime that you put the patient and then you put the hands in the back of the patient and then you say to the patient, please repeat like 99, 99. So when the patient repeat 99, you're gonna feel like if you don't feel that, it's because it's decreased taltive fremitus. Contralateral trachea shift is massive. Okay. Diagnosis, of course, you have to do a chest X-ray. That's the best diagnostic. If you see fluid right there, then you do thoracosynthesis. Okay, thoracosynthesis is when you do thoracosynthesis is to differentiate exudate from transudate. Okay, perfusion treatments most of the time is drainage. Okay? You have to remove that fluid. You have to put a chest tube. Thoracosynthesis, thoracotomy if the bleeding is a lot of, and also if the bleeding is ongoing, that means that is don't stop. Okay. Poliomyelitis. Poliomyelitis is a viral infection with poliovirus. Nowadays we have a vaccine for poliovirus. That's why cases of that condition in the United States extremely rare. Okay? Clinical manifestation, fever, headache, vomiting, diarrhea, constipation, sore throat, weakness, paralysis. Weakness, paralysis, that's one of the main characteristics because poliovirus affect the central nervous system, okay? And then you have weakness, paralysis, okay? Respiratory failure. Amyotrophic lateral sclerosis is also a neurological disease. I don't know why they are right here because we're talking about the lungs. They could produce problem in the lungs due to the muscle weakness, but it's not a lung disease, okay? But it's okay, let's gonna cover. Uh, nobody know the other name for this disease, amyotrophic lateral sclerosis? No? Do you remember the Ice Bucket Challenge? Yes? No? Okay, the Ice Bucket Challenge was due to this disease, okay, to collect, make fun, make research in that condition. Okay, another names, because maybe you could go to Google, okay, and then another name is Lou Gehrig's disease, because that was a famous baseball player that developed the disease, and basically a lot of people know that disease because of that baseball player. Okay, amyotrophic lateral sclerosis is the degenerative disease of the nervous system. The main characteristic is that you have affection in the upper and lower motor neuron. Okay? So you are going to have manifestation of the upper and the lower motor neuron both together. Okay? Progressive muscle weakness and wastings. Okay, those patients, there is no cure for that condition. Okay, there is only one medication, and it's just to give better life to the patient because it's not a cure. Okay? Muscular dystrophy, Duchenne disease, is one of the type of muscular dystrophy. We have more than one type. Duchenne disease is an X-linked recessive, that means that only affect males. Progressive muscle weakness, rapidly muscle become involved later years, 20 to 30. Okay, this is one of the few diseases that in order to make the diagnosis, you have to do a genetic test, okay? Guillain-Barré syndrome is acute polioneuritis, is immunological disease, demyelination of peripheral nerve, and could be due to the bacteria Campylobacter jejuni, and also due to some vaccines. There are some vaccines that can produce Guillain-Barré disease. Okay, the main characteristic is this one: ascending paralysis. Okay, so it's the patient that is gonna have muscle weakness, and then like paralysis that start in the lower extremity and start ascending to the upper body. Clinical manifestation: weakness and paralysis begin symmetrically in the lower extremity and ascend proximal to the upper body, and so on. You have to be very careful because if the paralysis start going up, and then you reach to the thorax and you reach to the C3, C4, C5, keep diaphragms alive. So that means you get to C5 and you paralyze the phrenic nerve. The phrenic nerve is the one that gives innervation to the diaphragm. The patient can't breathe. You have to intubate the patient. Myasthenia gravis is a problem in the neuromuscular junction, okay, especially in the postsynaptic receptor for acetylcholine, okay, and then those patients have weakness, okay. If they start like talking or counting 1, 2, 3, 4, 5, 6, 7, they are gonna get tired. They can reach, most of the time they can reach to 10. Okay, they 1, 2, 3, 4, they have tired because they get tired easily. Okay. Myasthenia gravis, 10 female, those are some statistic. Okay, oh, this is special, is in the neuromuscular junction. Okay, in the neuromuscular junction, we have the acetylcholine receptor. Right there is the problem. Okay? Symptoms often managed by appropriate therapy. Respiratory failure can be because of increased severity of the illness. Okay, and most of the time, one of the main clinical signs is vision problem. Okay, those patients have vision problems. Problem with swallowing. Kyphoscoliosis is a problem in the vertebral column. Okay, deviation of the vertebral column. Okay? Congenital POD disease. POD disease is infectious disease. Okay, POD disease is problem in the spinal cord due to TB. Pathogenesis, bone deformity, and chest wall resulting from kyphosis and scoliosis. Heart deformity. This condition is really common in female. Okay? And then you have to measure the severity, I mean the amount of deviation of the vertebral column. And according to the amount of deviation is the treatment. Okay, if the deviation is extremely severe, that can produce lung restrictions, lung problems, and then you have to do a surgery in those patients. Okay, that surgery could be due to could be performed from neurosurgeon or orthopedic surgeon. Clinical manifestation, dyspnea malsation, that is when the disease is really advanced and the deviation is extremely a lot of deviation. Okay. Pulmonary function checks X-ray. You have to do checks X-ray to see the deviation. Okay. And you see right here, it's about a degree of deviation. Okay, if the degree is more than 12, you see curvature more than 40, more than 60, those patients need a surgery. Ankylosis spondylitis. Ankylosis spondylitis is a problem. Is this okay? They have this marker, HLV27. There are 4 diseases that have that marker, and they are called seronegative diseases. Okay, seronegative diseases because those are inflammatory diseases, but the rheumatoid factor are negative. Okay, like anatase is always negative, but the inflammatory response mediator are increased. Okay, that like erythrosedimentation rate is gonna be high. Okay. Those patients with ankylosing spondylitis, the problem also they could develop lung disease, restricted lung disease, because there is no movement in the spinal in the vertebral columns, and those patients have a lot of pain, but that pain improves with exercise. That's why most of the time those patients love to do exercise, because when they are doing exercise, they get better. Okay. So then that produces a lot of stiffness in the morning, difficulty waking up from the bed in the morning, a lot of pain. And they have a special characteristic. Let me see if they put it right here. Okay, ankylosing spondylitis. Chest X-ray. That's the best diagnostic test. You have to do a chest X-ray, and you're gonna see something that is called bamboo spine. Okay, you could Google it, or write it down later. Google it. Bamboo spine. That's ankylosing spondylitis. Okay, see they have electrosedimentation rate is elevated. That's inflammatory mediated. But if you measure the anatase or any rheumatoid factor, all of the rheumatoid factor are gonna be negative. That's why it's seronegative diseases. Treatment NSAIDs, that's the main medication. NSAID for those patients for the pain. Flare chest. Flare chest is a trauma disease. Trauma disease. Okay, flare chest is due to a huge trauma. Okay, and in order to have a flare chest, you have fracture. Okay, this is the sternum right here, and then we have the ribs that are like this. Okay? In order to have flare chest, you need at least 3 ribs in a row, and the fracture has to be in 2 points. Okay, like this. Okay, so that means that this piece right here of the chest is not gonna work like the normal chest, okay? And then you are gonna see that the patient, when they breathe, that they get air, the chest expand. In that part, the chest is gonna depress, and when they release, that part is gonna expand. It's gonna be opposite, okay? And that's an emergency situations, because most of the time is due to a huge trauma, okay? You have to be very careful, because maybe the patient develop cardiac contusion, pulmonary contusion, that also are emergency diseases, okay? Clinical manifestation, of course, you see right there, paradoxical motion of the chest wall, okay? That's what you see when the patient is breathing, okay? Okay, the patient could have hypotension. Why? Because most of the time the patient have internal bleeding. Internal bleeding lead to hypovolemic shock. Okay. Diagnosis, you do an EVG, but you have to do chest X-ray. In the chest X-ray, you're gonna see the fracture. Disorder of obesity. Obesity is a restricted lung disease. It's a type of restricted lung disease, because due to the excessive body fat, the patient can't breathe properly. Okay, then you have to know the BMI. Okay, body mass index. Body mass index normally as a general proportion go to 18 to 25. Okay? So if you are in that range, your body weight is ideal body weight. Okay, it's a normal body weight. You are below 18, you are underweight. You are from 25 to 30, you are overweight, and from 30 up, you are obese. Okay, 30 to 35 is obese, and over than 40 is morbidly obese. Okay, those patients with morbidly obese are the ones that are at risk to develop restricted lung disease. Okay. More common women than men, and those are some statistic. Pathogenesis, of course, excessive calorie intake. It's not I get fat because I only drink water. No, it's because you are eating a lot. Maybe associated with hypoventilation or airway obstructions, sleep apnea syndrome. Okay, that's another complication of obesity. Okay, sleep apnea syndrome are the people that at night they snore a lot. Okay, and really loud. Okay, and it's because they have obstruction at night and they develop apnea. They stop breathing at night. Also, those patients, you most of the time, not always, but most of the time, you do a CBC, they're gonna have polycythemia. Okay, the hemoglobin is gonna be high. It's a compensatory mechanism. Clinical manifestation: decreased alveolar ventilation, somnolence in the daytime because they don't sleep well at night, shortness of breath, core pulmonary impotency, headache, enuresis. Diagnosis: self-evidence of examination, ABG, you can see that, hypoxemia and hypercapnia, pulmonary function test, and also laboratory. Treatment: O2, calorie intake, you have to make restriction of calorie intake, aerobic exercise, and if the patient is extremely obese, maybe the patient is candidate for gastric bypass. That is the surgery that you remove one part of the stomach. Now we have pneumonia. Pneumonia is an inflammatory reaction of the alveoli, an interstitium caused by an infectious agent. Okay? Causes aspiration of oropharyngeal secretion. Thus, aspiration of oropharyngeal secretion is in patients that are hospitalized or patients that have neurological problems, okay? Like a stroke, okay? Because maybe they have decreased the gut reflex. If they have decreased the gut reflex, the patient aspirate the contents and can produce aspiration pneumonia. inhaling of contaminants and contaminant from the systemic circulation. Pneumonia classification: community acquired, hospital acquired, bacteria, typical, and viral. Those are one type of classification. Most of the time, they just classify the pneumonia in common, community acquired, and hospital acquired. Okay? A high risk, elderly, of course. Patient diminish the gut reflex, serious ill, hospitalized patient is hospitalized pneumonia, nosocomial pneumonia, that's another name. Hypoxic patient, immunocompromised patient, especially patient with AIDS. Patient with AIDS, HIV/AIDS, they are at risk to develop one type of pneumonia. We have anaerobic bacteria present at the lung abscess, necrosis pneumonia, and emphysema, usually caused by aspiration of normal oral bacteria into the lungs. Okay, and what happens is that the oral flora are anaerobic bacteria. Okay? Mycoplasma pneumonia is the most common type of atypical pneumonia. Okay? Mycoplasma pneumonia. Legionella disease from Legionnaires, that's a bacteria, and is transmitted by potable water, okay, condenser cooling from the air system, okay. Produce fever, diarrhea, that's one of the special characteristic, diarrhea. Okay. Abdominal pain, okay, treatment, macrolide. Macrolide is a type of antibiotic. Opportunistic pneumonias like this one, pneumocystis jirovecii. Pneumocystis jirovecii is the pneumonia that you see in patients with HIV, HIV/AIDS especially. Aspergillus fugimatus is another opportunistic infection, but this is a fungal infection. Pathogenesis are acquired when normal pulmonary defense mechanisms are compromised. Organisms enter the lungs, multiply, and trigger pulmonary inflammation. Okay, that's how you develop the pneumonia. Clinical manifestation, of course, the patient is going to have fever, cough, pulmonary sputum, cackle. Those are sounds in the lungs. Manifestation: viral is the upper respiratory prodrome, fever, non-productive cough, hoarseness, coryza, accompanied by wheezing and rheal. Chlamydia pneumonia, cough, tachypnea, rheals, wheezing, and no fever. Clinical manifestation of mycoplasma: they have fever, cough, headache, malaise. Diagnosis: always you have to do a chest X-ray, okay, plus the CBC. Okay, forget about this curve 65, that's not a test, okay? It's a diagnostic criteria. I don't know why they put it right here. A laboratory, you have to do the CBC. Okay? Curve 65 is a criteria to see if the patient is going to be treated as outpatient, if the patient go to the wards, or if the patient go to the ICU, okay? Treatment: antibiotic therapy based on sensitivity and culture. That's why you have to culture the patients always to see, do the antibiotic sensitivity test. Severe acute respiratory syndrome, SARS, like COVID is a type of SARS. Coronavirus associated with SARS-CoV. Primary mode of transmission through person-to-person, respiratory droplet, cough, sneezing. Clinical manifestation: fever, malaise, headache, non-productive cough, dyspnea. Diagnosis: exposure to SARS or travel to high-risk area, chest X-ray, laboratory, presence of the virus. To do the nasal swab to see if the virus is present. Treatments: there is no treatment basically symptom of pneumonia, hospitalized, O2 therapy, mechanical ventilation if the patient is extremely severe, and isolation. That's special because remember it's transmitted person to person. Pulmonary tuberculosis. Pulmonary tuberculosis is a high-risk individuals. Uh, like high-risk individuals are people that are immunocompromised, people that are in jail, immigrants from endemic area, people that are in hospital, people that work in hospital. Those are people at high risk to develop those, TB. Multi-drug resistant TB causes are reported to a local and state health department. Always when you see a patient with TB, you have to report to the CDC. Mycobacterium tuberculosis, of course, that's a bacteria that produces TB. It's an anaerobic bacteria. It's as a fast bacillus. Okay. Causes involvement of distant or let me see. Infections, inhaling of small droplets, spontaneous cough. Involving the distant organ, disseminated disease, miliary tuberculosis causes hematogenous disseminated of organs. The problem is that the TB, normally we know the pulmonary TB, but the TB could go to any part of your body. Like for example, the TB go to the vertebrae and produce osteomyelitis in the vertebrae. That's the POP disease, but could go to the liver, to the pancreas. Classification is primary and secondary. Okay, primary is when you are exposed for the first time to the TB. Basically, you don't develop any signs and symptoms, but you develop the granulomas in the lung. Okay, then later, if you have any problem that your immune system is decreased, those granuloma is released, and then you have the secondary exposure, and then is when you develop the sign and symptom. Okay, the active TB. Entry of mycobacteria into the lung tissue, alveolar macrophages. You see, that's always they affect the T lymphocyte and the macrophages. Okay. Pathogenesis, reactivation occur if immunosuppressed. Okay, if you're immunocompromised. It's gone tubercle complex, parenchyma complex, lymph component. Classification, history of contact with infected person, low-grade fever, chronic cough, most of the time you have hemoptysis, night sweat, special fatigue. So all those symptoms you also see in patients with cancer. Okay, and one of the main difference between pulmonary tuberculosis and patient with cancer is the age. Okay, because pulmonary tuberculosis is more prevalent in young people, okay, in the 40s, in the 50s. You have all those signs and symptoms in a patient with 60, 70, with a long history of smoking, you think more toward to the cancer. Weight loss, malaise, anorexia, you see basically the same manifestation of cancer. Diagnosis, spectrum culture, definite diagnosis, 3 consecutive morning specimens, DNR, RNA amplification, pulmonary function test, checks X-ray, TB skin. TB skin is for screening. Okay? If the patient comes with tuberculosis, you don't do this test because that test takes like 48 hours. So you don't do that test. You don't need it. Treatments is a 4-drop therapy. Okay, you have to use 4-drop. Okay? Because treatment is divided in two. We have prophylaxis and we have the actual treatment. Okay, the actual treatment is when you have the active tuberculosis. Okay, if the PPD you do a screening, the screening test is the PPD. If the PPD is positive, you do the X-ray. Okay, there are 3 tests. You have to do PPD, X-ray, and there is another test. Okay, so if you have PPD positive, you do prophylactic. If you have X-ray positive, you do prophylactic. And if you have the last test positive, then you do the active treatment with 4 drugs for 9 months. Treatments provide safety, most effective therapy, but there are 4 medications. Okay, that is I don't remember. I don't remember the name of the medication. But it's rifampin, isoniazid, and the other 2 drugs. And we have question: which information is correct regarding restrictive pulmonary disorder? What is the answer? Yes, exactly. The answer is C, okay, right here. And right here you have a clinical case. That clinical case is for you to study, okay? You don't have to do any report, you don't have to do anything. And all the answers are in the original PowerPoint.